So BCMA-directed therapies are a really exciting new advancement for patients, and we can target them in three different ways: antibody-drug conjugate, bispecifics, and CAR-Ts. And here in this paper, we were looking at the infectious complications of BCMA bispecifics, because what's unique about BCMA bispecifics compared to those other two modalities is that patients are getting treated repeatedly, as opposed to CAR-T, it's considered a one and done. And with ADC, because of the ocular issues, there was very intermittent dosing. So this is the only product that's been consistently given on schedule. But we've seen that there's been infectious complications, not just all grade, but also grade 3 and higher. And so in our paper, what we looked at is what is the kinetics of the infection? And what we found is that the rates of grade 3 to 5 infections were high, and they continued to increase over time. There was no plateau. And it approached 60%. This was in a study of about 37 patients at Mount Sinai that were treated with BCMA bispecifics. Second, we found that severe hypogamma, we're looking at less than 200, was universal amongst these responding patients. And then we also found, which I think is really important from a management perspective, IVIg can really help. And we found that grade 3 to 5 infections were 80% lower on IVIg, and 89% lower for bacterial grade 3 to 5 infections, suggesting that there's a role for IVIg in primary prophylaxis. In contrast, neutrophil lymphocyte counts were not significant factors, and CMV reactivation was common, suggesting that these need to be monitored. And I think this paper helps us give this really effective, potent therapy, but in a safe fashion to our patients.